Welcome to the lecture on traumatic dental injury part 3. I am Dr. Fawaz Siddiqui from Department of Pediatric Dentistry, and in this presentation we're going to look at all the traumatic dental injuries that occur to the permanent teeth, occur to the permanent teeth, and we're going to look at how to manage them. The learning objective or the intended learning outcome of the presentation on dental traumatic injury is what you see on your screen. And in this particular presentation today, we are going to analyze the protocols in the management and prevention of dental injuries to the young permanent teeth. Now, the case study that I am showing to you is a very common type of dental injuries that young patients in mixed dentition come to the dental clinic with. And as a dentist, you are supposed to diagnose correctly what kind of traumatic injury this is, and of course you should know the steps in the clinical management of this case, and therefore once you know the steps, you'll be able to carry out those steps and save the permanent teeth. So let's begin. First and the foremost thing is you must know how to examine the patient in a systematic way so you don't miss out on any important findings. So when you're taking the history of the injury, it is very important that you take a record of patient's details. Now this will be very important for your medical legal purposes and of course for your patient record and for follow-up. So it's very important that you very correctly record the name, age, gender, address and the contact number of the patient. You will also have to inquire on when did the injury occur, because this will decide on the treatment plan, and you will also have to ask them where did the injury occur. So this will also help us to decide whether the child would need any tetanus booster dose in case the injury has happened on a playground with the soil contamination. So you need to ask where has the injury occurred. Then you need to ask how did the injury occur. Now this question will answer any injuries that could be present along with the dental injuries. Okay, for example, in the road traffic accidents, or the injuries happened during sports activity. So we must know how the injuries occurred. So if it is a direct contact with a hard object, or a indirect contact with a hard object or resilient object, so this will help us to anticipate the kind of dental injury that the patient may have, and therefore affect our treatment planning. Then you need to ask if any treatment was taken before the child has come to you, any first aid that was given to the patient, or anything done by the previous dentist and now the patient has come to you. Then lastly, in the history of injury, you must ask for any history of previous dental injury, because sometimes the patient's children are prone to traumatic injuries, prone to dental injuries, and they keep having accidents at home or at school, and they present to you with previous dental traumatic injuries, and you have to be aware that this is a frequent happening, and then you have to take some definite treatment or definite steps to avoid future dental trauma. Then you come to the general examination. In the general examination, you must inquire about the patient's general health, the medical history of the patient, and how is the patient doing physically. If the patient has diabetes, in juvenile diabetes, or is he having bronchial asthma, is he having any epilepsy, any bleeding disorder. So you have to take all these medical history. And last in this examination, but the most important, is any history of loss of consciousness, any history of vomiting, drowsiness or headache. All these will, if present, indicates injury to the brain. And this injury, if it is there, if these symptoms are there, if these signs are there, first thing, the patient has to be referred to an emergency department of the hospital to have his brain assessed, and then only we can go in and then do the dental trauma. So life of the patient is important before we do any dental treatment. So we need to refer the patient to the emergency department in case he has history of loss of consciousness after the traumatic injury, or history of vomiting after the injury, or there is a drowsiness or headache. Very important. So once you complete that, you come to the extra oral clinical examination. So you have to look for extra oral wounds. The presence of wound will tell you the type of injury. For example, if the lips are lacerated, you will be expecting to see some injuries on the gums, on the adjacent tooth structure, periodontal ligaments. And of course, you also have to assess the facial skeleton and not rule out any mandibular fracture, maxillary fracture, alveolar fracture, orbital fracture. So you need to be very, very carefully examine the patient on the extraoral facial skeleton for any signs of traumatic injuries to the basal bone. Again, this is a priority to dental treatment. So if there is a fracture of mandibular bone, the mandibular bone has to be fixed before we go into look at the dental traumatic injuries, because sometimes when you are treating the mandibular fracture or maxillary fracture, there will be some teeth which will be lost. So we always have priority for treatment of basal bone before dental injuries. Then we come to the clinical examination of the intraoral. We'll have to look at everything. Okay, don't focus only on the traumatic injury side, but have a look at everything else. So look at the gingiva, the mucosal injury, any lacerations, abrasions. You'll have to look at the crown of the teeth. You have to look at the fracture. Also have to look at if the teeth is not fractured, has it moved from its socket, and then the occlusion, and then ask the child to close in centric occlusion to see if there is any disturbances in occlusion. This also tells you if there is a problem with the fracture of basal bone, or the tooth itself has displaced, which is causing a disturbance in occlusion. Then you have to palpate using your finger in the buccal vestibule to look for any tenderness of the alveolar bone, which is again gonna give you some signs and symptoms of trauma, maybe fracture. And then in terms of the teeth which are in site of trauma, you have to do test of tenderness to percussion, and also you have to listen to the sound that comes with the percussion. So this sound also tells us if the tooth is stuck in the fractured bone or the tooth is loose. So you have to hear for the percussion sound as well. And then of course, if the patient is complaining of any spontaneous pain coming from the teeth, which is a sign of pulpal injuries, which will need immediate care, otherwise the pain will not go away. And then you have to do pulp sensibility test. Now pulp sensibility test is a test to check whether the nerves, the nociceptors in the pulp, the sensory nerve endings in the pulp are still alive or they have degenerated. So we have electric pulp testers, and then we have thermal pulp testing using hot and cold. So we have to perform both of these to have a baseline data of the readings, so that when the patient comes back on follow-up, we compare the baseline readings with the follow-up readings, and then we will come to know whether the pulp is recovering or the pulp is getting degenerated. So once you have completed your examination, you have to make a diagnosis. The correct diagnosis will help you in planning the correct treatment of the patient. So if there is a wrong diagnosis, you will do a wrong treatment plan, then the treatment will fail. And this will cause a lot of frustrations for you and maybe a medical legal case from the patient. So you have to make the correct diagnosis. If you've done your clinical examination very nicely, very properly, the diagnosis will fall into one of these classification of dental traumatic injuries by WHO. You have learned this in the first lecture series, the classification. So diagnosis could be enamel infraction, enamel fracture. We could be uncomplicated. That means maybe just the fracture of enamel, or maybe the fracture of enamel and dentine, or it can be a complicated enamel fracture or a complicated crown fracture. So which would mean that enamel is involved in the fracture, the dentine is also involved in the fracture, and the pulp is also involved in the fracture, and the part of the tooth has broken away, as you can see in the middle picture, in the pictures that I have shown below, the first two starting from the left side. Then you can have a crown root fracture. Crown root fracture means the enamel is involved, the dentine is involved, and the cementum is involved. So this will be uncomplicated if the pulp space is not involved, and it could be complicated if the pulp space is involved. So this is the third picture in the row which shows a crown root fracture. And then lastly, we can have a root fracture. So the crown is intact, but the root has fractured within the alveolar socket. So this fracture can be a horizontal fracture of the root, or a vertical fracture of the root, or maybe an oblique fracture of the root, right? So all this you will come to know only when you have done your clinical examination and you have completed your radiographic assessment. For your radiographic assessment, you must take multiple, at least 3 radiographs of the tooth to identify the fracture line. Okay, so it may happen that just one periapical view may not give you the visibility of the fracture line. So maybe you have to take an occlusal with a periapical, with a mesial shift, with a distal shift, with the slop technique, and try to have a multiple view, because X-ray itself is a two-dimensional view of a three-dimensional object. So we need to have at least 3 radiographs to confirm the fracture line and of course the diagnosis. Then you can have injuries to the periodontal tissues or the supporting tissues, which can take in the form of concussion, subluxation, extrusion, lateral luxation, intrusion, and avulsion. So we will have a look at these in a more detail as we go along. So there could be injuries to the dental hard tissues, there could be injuries to the periodontal tissues or the tooth supporting tissues. So the diagnosis will fall in one of these categories. So once you have made the diagnosis and you have to start your treatment planning, there are certain things that you must look at, especially when the pulp is involved. That means when you have a complicated crown fracture or you have a complicated crown root fracture. So once you have an exposed pulp, you have to look at the vitality of the pulp. So is the pulp vital, or is the pulp necrosed, or is the pulp degenerating, or is the pulp hyperemic? Because this will again help us to decide what kind of treatment is possible to do. The size of exposure, is it pinpoint, pinhead, or it is more than pinpoint and pinhead? Again, our treatment will depend on this. Time elapsed since exposure, this will tell us whether the pulp is freshly exposed. That means there are chances to do direct pulp capping, or if the patient has come to you after 72 hours, after 1 week, the pulp may have undergone superficial necrosis, superficial chronic inflammatory changes, and therefore direct pulp capping may not be useful. So the time lapse with exposure is very important for us to know, to decide how best we can save the pulp. Then the stage of development of the root apex. Because we are dealing with children, in the mixed dentition stage, there will be cases where the root apex may be complete, the tooth may be mature, or it may not be complete, or the tooth may be immature. So the date of completion of the root of each tooth will help you decide what kind of development of root apex are you looking at. And then of course you have to take a radiograph to confirm the status of the root apex. This will again tell us what treatment we can do and what treatment we cannot do. Then lastly is the restorability of the fractured crown. This has to be assessed, because there's no point doing a heroic endodontic treatment on a tooth on which the crown cannot be restored to normal form and function, right? So it is unwise to do extensive endodontic treatment where you cannot replace the tooth's crown back again. So if the tooth crown is not restorable, maybe you need to go for extraction, and then if it is restorable, maybe you have to go for a post and co-restoration and treatment like that. So these factors will help you decide how best you can manage the traumatic tooth, or the factors which will influence your treatment plan. Right. So again, each tooth reacts to trauma differently, right? And the researchers have found out that the tooth reacts to the trauma, or say more specifically, the pulp of the tooth or the periodontal structure of the tooth reacts differently to the trauma. Okay, so these are some of the reactions a tooth can have to trauma. A very simple example is that a patient comes to you with a mild traumatic injury of the tooth, and the tooth becomes grayish dark colored after 1 year of the trauma, right? So this means something has happened inside the tooth. So this particular part, that is the reaction of the tooth to trauma, will help you understand what happens to the pulp inside after trauma. So when the tooth is traumatized, initially there is a pulp hyperemia. So pulp hyperemia is basically your reaction to trauma, which is basically inflammation of the pulp. So there will be increase in the blood supply in the pulpal space, and you can view this by a translucent light, and the tooth will appear pink as compared to your contralateral tooth or the adjacent tooth. So this is pulp hyperemia. This is very common after traumatic injuries. But if this pulp hyperemia, which is the increase in the blood flow, goes on for more than 3 weeks, right? It will cause internal hemorrhage. That means the congestion of the blood supply in the pulp chamber will cause the blood components to break up, and then the hemosiderin, the hemoglobin will break up from the red blood cells, and these hemosiderin from the hemoglobin will enter the dentinal tubules, and they will cause internal discoloration of the tooth, and this is called as internal hemorrhage. So again, the tooth will get temporarily discolored, and as the pulp hyperemia will reduce, the internal hemorrhage will reduce, the tooth normally comes back to its original color. But then again, you must be aware that internal hemorrhage can happen, which can cause temporary discoloration of the tooth. The third reaction that can happen is that the pulp space may undergo obliteration, okay, which is called as calcific metamorphosis of the dental pulp. So what happens is, because of the trauma, the totipotent cells in the pulp space, they get converted into blastic cells, and then they randomly start depositing calcific uh, uh, minerals in the pulp space, like odontoblast like cells or cementoblast like cells or osteoblast like cells, and then you find there's an obliteration of the pulp space. That means pulp space becomes smaller, smaller and smaller and smaller, and because of this pulpal space getting obliterated by calcific tissue, the tooth will normally start to discolor or have a color from light yellow to yellowish color. So this is very common in primary dentition, not so in the permanent dentition, but again, yes, it can happen that when you look at the tooth after 1 year and take an x-ray, and then you suddenly find the pulp space has become very, very small, and this is because of calcific metamorphosis of the dental pulp. Now this poses a problem, because if you want to do an endodontic treatment after 1 year, it will be difficult, because the radicular pulp has become so narrow that it will be very difficult to negotiate through it. The other thing that can happen because of the trauma to the tooth is the internal resorption. Just like how the totipotent cells get differentiated into blastic cells, they can also get differentiated into clastic cells. And these clastic cells, say for example odontoclast-like cells or osteoclast-like cells, these cells start resorbing the dentine, or start eating the dentine from within the root canal, and then you will have internal resorption within the canal, and then you will certainly find the canals are very, very wide, or there is certain areas of resorptive bay. So similarly, how resorption can happen inside the root canal, the resorption can also happen on the outside of the root surface, that is in the periodontal ligament. So what happens is, because of the damage, some of the periodontal ligament gets damaged and they undergo necrosis, and this forms an or this instigates an inflammatory response, and this inflammatory response starts to resorb the tooth from its outer surface, and this is called as external resorption. So it will be like a moth-eaten appearance on the radiograph. One more type of resorption is the replacement resorption. So what happens is that as the tooth is getting resorbed from on the external surface, the resorption area is getting replaced by bone. Okay, and this is what happens in ankylosis. So there is a resorption happening on the external surface, and the resorptive areas are getting deposited by the bone, and then the tooth is strongly anchored to the bone, and which is called as ankylosis. So these three types of resorptions can occur. So if the periodontal ligament is inflamed, you will be looking at external root resorption, or if the pulp has become inflamed, you are going to look at internal resorption, okay, and then replacement resorption can happen again from the outer surface. Now the external resorption can be because of the pulpal inflammation within the cells. So because of the accessory canals, it can so happen that the inflammatory cells from the pulp enter into the periodontal ligament space, and then they start resorbing the external surface of the root. So it can happen. Okay, and the last reaction of tooth to trauma is the pulp necrosis, right? So because of the trauma, you have pulp hyperemia, internal hemorrhage, and the pulp is not able to recover from this internal hemorrhage. There will be stasis of the blood, and then the part of the pulp where the blood flow cannot reach will undergo necrosis, and the necrosis will spread to the whole of the pulp chamber, the pulp space, the radicular pulp, and the tooth will undergo pulpal necrosis. So these are the things that can happen to a tooth after trauma, and therefore it is very important to have to monitor the tooth periodically in order to diagnose these conditions and take immediate steps to protect the pulp. Now the objective of management of traumatic injuries is to retain the tooth into the oral cavity, right, in its form and function. So that is the objective. So Once you realize that something is going on, these reactions are going on, we need to intercept them to protect the tooth. So let's begin with the first traumatic injury, that is the infraction. So what infraction is basically is an incomplete fracture of the enamel. Okay, so enamel is just fractured on its labial surface or palatal surface. So there is an incomplete fracture and the tooth is asymptomatic, and of course you will not see any radiographic findings. And here the best you can do is either you can leave it alone or you can use your composite resin to seal the crack. Okay, so this is all we need to do in infraction. So to diagnose infraction, you need to have a good light, and maybe a translucent light will help you visualize the fracture. Next one is the enamel fracture. Okay, so enamel fracture is a fracture which involves only the enamel, okay, not the dentine. So obviously there is no tenderness on percussion or there is no mobility because the uh, the enamel is only fractured and the dentine is not involved. So radiographically also you will just have you will just see loss of enamel. In this case, once depending on how much enamel is fractured, you can do something called as tooth fragment reattachment. Okay, where the fractured fragment of the tooth can be put back into the fractured area, and we can use our flowable composite to uh, set the fractured fragment on the tooth just like the original one. Or you can do just the contouring. If the fracture is really mild, okay, you can use your polishing disc to smoothen out the fracture, and that is all that will be required. Or you may have to go for a composite resin restoration like I have shown you in the clinical picture here. You can use a composite resin restoration to restore the tooth back to its form and function. Okay, so these is taken from literature where the tooth fragment reattachment procedure has been shown. So the picture A is where the tooth has fractured, and the picture B is if you see the enamel has fractured and the dentine is visible, and the C is the fragmented tooth, and then the rubber dam is put in the D and the etching has done. The E shows the placement of the calcium hydroxide liner over the exposed dentine, and F shows preparation of a space for the flowable composite. And then of course G is a step where you etch bond, and using the flowable composite you place the fractured fragment back on the tooth, and then you place again your sealant in the fracture line, and then of course polishing will help attain a very lifelike appearance. This is very important because it's a more biological approach. Okay, so instead of doing a composite restoration, try using the fragmented tooth and you will get a better result. Alright, so this brings us to the next fracture, which is called the uncompleted crown fracture, which basically means the fracture involves loss of tooth where enamel and dentine has been lost. So there are exposure of the dentinal tubules, and if you leave these too long, dentine exposed for too long, you will have a pulpal hyperemia or pulpal inflammation. So radiographically you will see just loss of enamel and dentine, and then you can of course go back and you can do the tooth fragment reattachment technique to restore the tooth back, or you can use a composite resin restoration but with a GIC base and a calcium hydroxide liner. So if your fracture is very close to the pulp, say about a millimeter, the remaining dentine thickness is 1 millimeter, you want to put a calcium hydroxide liner followed by a GIC base, which basically covers the gingiva, which basically covers the exposed dentine, and then you go ahead and do a composite resin restoration to achieve an aesthetic results. Or you can have a problem where there is a fracture of enamel and dentine which involves the pulp, like the clinical picture shown on your screen. So there is a fracture of enamel, dentine, and the pulp is exposed, and then now you have to look at what we can do to protect the pulp. So here remember we talked about the factors influencing the management of teeth, where we looked at the time of trauma, the size of the pulpal exposure. So all those will come into the picture here. So depending on the scenario, we have to take a decision. So you can have a situation where you have an immature tooth, that means open apex, If you have an open apex, you have to let the apex open physiologically. So you have to go for direct pulp capping using calcium hydroxide or MTA or biodentine. A lot of newer materials are available. Or you can do pulpotomy. So you want to do a pulpotomy, the best is to start with cervix pulpotomy, okay, and then you can go in for cervical pulpotomy depending on control of hemorrhage. Okay, so pulpotomy we have dealt with in pediatric endodontics before. So this is for the immature tooth. So for mature tooth where the apex is closed, the best is to go for a root canal treatment, but you can also do direct pulp capping and cervix pulpotomy. Also, it's not contraindicated, but yes, the success rate is different, and people recommend doing RCT, but you can go ahead and do DPC, direct pulp capping or pulpotomy for a mature tooth as well. But again, you have to keep the tooth on a follow-up for monitoring if necrosis happens. And of course, you can again use tooth fragment reattachment to to achieve aesthetic results. So if the tooth fragment is not available, you have to do a composite restoration, but if it is available, go for tooth fragment reattachment. Okay, so this one, this I have made it more clearer for you for your decision making. So if you have a complicated crown fracture with vital pulp, and if it is a young permanent tooth, that means the apex is open and it's a pinpoint exposure and the patient has come within 24 hours of exposure, go for direct pulp capping, the prognosis is very good. Or if the patient has come after 72 hours and there is an extensive pulp exposure, you go for a pulpotomy, cervix pulpotomy, cervical pulpotomy, or if it is really extensive exposure is there, you can go in for apexogenesis, of course using which is part of pulpotomy or cervix or cervical pulpotomy, or you can go for apexification. All right, so it's basically open there. In the permanent tooth, if you can do direct pulp capping, and you can do root canal treatment depending on the exposure and the exposure time. So best time would be if the patient comes to you within 24 hours, direct pulp capping is very successful. But if he comes within 72 hours, then it's best to do a cervix pulpotomy. That means you just remove the 2 millimeter of the exposed pulp, obtain hemostasis of the radicular pulp of the remaining pulp, and then go ahead with calcium hydroxide or MTA or biodentine dressing, followed by GIC, followed by composite. Okay, so this will help you decide what to do. And in similar case scenario, you can have a non-vital pulp. So non-vital is very much clear. So if the apex is open, go for apexification. If the apex is closed, you go for an endodontic treatment. There's no two ways about it. So that was regarding the crown fracture. Now we talk about crown and root fracture. So uncomplicated crown and root fracture. So we have fracture which is involving enamel, dentine, and the cementum, and it's not involving the pulse space. Okay, and the gingival, and one of the margin of the fracture will be subgingival. Okay, this makes it difficult for us because we cannot achieve good isolation to carry out our composite resin restorations, and it's really a clinical challenge. So what we have to do here is we have to remove the fractured fragment of the crown. Okay, then we perform the root canal treatment, then we perform post and core restoration, and then we perform crown lengthening, try to expose the fracture line which is subgingival. You can you do a gingivectomy or osteotomy, osteoplasty to expose that gingival fracture line so that you can have a good isolation. And then of course you can go for a full coverage crown, or you can again go for a fragment reattachment technique, whichever. But this again requires a lot of skills. The way out, easiest way out would be extraction followed by an implant, or you can do a bridge. But again, this is not very advisable because if the child is really young, you need to retain the tooth in the permanent tooth in the oral cavity for as long as possible. So go for the more skilled treatment. It will give you a better outcome in the future life of the child. So now we have crown root fracture, which is complicated. That means the pulp is involved. So if you see on the radiograph on your right, you will see the fracture line is very clear, which is involving the pulp and extending in the subgingival area. And again, this is a clinical challenge to restore, but essentially we do the same treatment that we do for the uncomplicated crown fracture. We remove the crown fragment, and then if be possible. If the root is having open apex, we go for a pulpotomy or direct pulp capping, or if the apex is closed, we can go for a root canal treatment and a post and core restoration. Post and core restoration is required because the crown, the loss of the crown needs support, and post and core is the best support that can come from within the tooth. So this will require root canal. There's no two ways about it. And then of course you have to do crown lengthening for a full coverage crown, because we need to achieve a good marginal seal. So you have to expose the gingival fracture line. So you have to do gingivectomy, osteoplasty, osteotomy to visualize the gingival fracture line. And then of course extraction, you can go for an immediate implant or a delayed implant, whatever. But again, for us, for pediatric dentistry, this would be our last option. Then we come to the fracture of the root. Okay, so the crown is intact, but the root has fractured. Okay, so from the radiograph from your screen, you can see there is a horizontal root fracture between the middle third and the apical third of the central incisor, the 1-1. And these fracture lines can be at 3 planes: apical third, the middle third, and the cervical third. And the treatment for all these are a little different. So we need to identify where is the fracture line. So again, you have to take 2 or 3 radiographs to ascertain where is the fracture line, or is it oblique, or is it vertical, or is it horizontal. Okay, so when it comes to the treatment, vertical fractures are having a very poor prognosis, and you want to go for extraction of the teeth. But if you have an oblique fracture or a horizontal fracture, you may want to reposition the tooth and stabilize using a flexible splint. The duration of the splinting we'll see later in the presentation, but you have to go for repositioning of the tooth and stabilizing using a flexible splint, and then you monitor for pulpal necrosis. And if it occurs, you have to perform root canal treatment of the coronal segment, because of course the apical you may not be able to negotiate, but you can do the root canal of the coronal segment to save the tooth. So very important to identify the level of the root fracture. Now when you talk about root fracture, we have to talk about how the root fracture heals. So there are like 4 ways in which the healing occurs, and we have absolutely no control on the healing process. Okay, so one of these 4 will happen once you complete the procedure of repositioning and stabilization of a root fracture. So the best would be when the healing of the 2 fracture segments are joined together by calcified tissue, a bridge of dentine and cementum. That would be the best. Okay, but seldom happens. You can have healing with the interposition of a connective tissue separating the 2 fragments. So the 2 fragments are separated by the connective tissue, and the coronal portion of the fracture will always have a slight mobility which is asymptomatic. Or you can have interposition of bone and connective tissue. Okay, so again the mobility will be less, but again there will be some mobility in the coronal portion, and it's quite frustrating because the coronal portion is mobile, and then you're wondering how to make the coronal portion firm again. So basically you cannot do anything. The worst case scenario is that there is no healing, and the space between the 2 fracture segments is occupied by a granulation tissue and inflammatory tissue. So the tooth is asymptomatic, but there is a mobility of the coronal portion of the tooth, and then it's again very frustrating on what to do with the particular tooth. So these 3 kinds of healing can happen, and then you can postpone the treatment if in case of interposition with the granulation tissue and inflammatory tissue till a later date, where maybe you want to extract the tooth and put an implant when the child has finished his growing phase. So you have to take into consideration the type of healing in cases of root fracture. Okay, so with this, with the last slide, we finished the management of dental injuries to the hard structure of the tooth and the pulp. And from this slide, we talk about the management of injuries to the supporting structure of the tooth or the periodontal ligament. So first one is the concussion. So concussion is basically the tooth has been vigorously shaken in its socket, but it does not show any mobility, right? But it is tended to percussion, is tended to palpation. Okay, and the pulp sensibility test will come out positive. So this is just like having a brain concussion. So it is just moved within the socket. So basically there will be no radiographic findings, and you need not do anything, okay, except maybe put the patient on a soft diet for 3 to 4 days, and keep a monitor the pulpal condition for at least 1 year to forward. Why do we need to monitor the pulp condition for 1 year? Yes, to diagnose any chance of pulp necrosis or maybe external root resorption, internal root resorption. So we have to intervene if it happens. So concussion is basically okay, no treatment required, just monitor the pulpal condition of the tooth. Next one is subluxation. Now subluxation is where the tooth has moved within the socket. Okay, so it is moved within the socket. It's not come out, but it has been vigorously shaken within the socket, and it's so vigorous that it shows mobility. And the typical pathognomic sign would be bleeding from the gingival sulcus. Okay, and then of course the tooth will be tender to percussion, tender to palpation, and the pulp sensibility test will come out positive. So for this you need to stabilize the tooth because the tooth is mobile. So you have to put a flexible splint to stabilize the tooth for 2 weeks of time. Okay, and after 2 weeks you remove the splinting and then you again monitor the tooth. So later in the slide, be sure to focus on the slide where we will talk about the duration of splinting, and we will also talk about the type of splinting that we can put. Okay, so for now just understand that for subluxation the splinting is required. So subluxation was when the tooth has moved within the socket. Okay, now we have subluxation, kind of luxation, which the tooth is moved out of the socket or into the socket, or the tooth has moved in the socket, or the tooth is displaced in the socket. So this one that you see on your screen is the extrusive luxation. That means the tooth has come out of the socket. The clinical picture is also very evident that the tooth has come out of the socket. This is called as extrusive. So the tooth has come out in the axial direction out of the socket, but it's not completely displaced. Okay, so this will be having excessive mobility. This will have disturbance in the occlusion. Okay, it will be very tender on palpation and the touch. And when you take a radiograph, you will see that there is a widening of the periodontal ligament space in the apical area. So no rocket science. What you need to do is you have to reposition the tooth back into the socket, and then you need to stabilize with flexible splint. Now all this you must do under local anesthesia. Okay, so this is a very painful condition. So any repositioning that you do, it has to be under local anesthesia, maybe local infiltration for one or two teeth, or maybe you want to go for a block if you have a number of teeth in the injury site. So you reposition using your hands. Okay, use your fingers, try to put the tooth back into the socket and take a radiograph, make sure it's in the correct position as much as possible, and then you stabilize with a flexible splint. And then again you have to monitor the pulpal condition, and the first sign of pulpal necrosis you have to start your root canal treatment. So this is extrusive luxation. Now we have extrusive luxation where the tooth has come out of the socket. You have lateral subluxation where the tooth has moved palatally, lingually, or in the labial direction, but basically it's not come out of the socket. Okay, so because this is associated with fracture of the alveolar process, okay, the apex may get wedged between the fracture of the alveolar process, like you see in the picture here where the root apex is wedged between the fractured labial plate and the basal bone. So here the tooth will not move, there will be no mobility, the tooth will be stuck. Okay, and when you percuss the tooth you will get this metallic sound. That means the tooth is ankylosed. So here when you are trying to reposition, okay, you have to carefully reposition because you have to loosen the tooth in the socket and then put it back into its original place, and then you have to go for stabilization. So this will require some work. Okay, it's not very easy to reposition, so maybe you have to use your forceps to disengage the tooth from its the place where it is wedged, and then reposition it back, and then reposition the alveolar process back, and then you do your stabilization with flexible splinting. Okay, now this because the apex has moved the apical foramen from its apical foramen. That means all the blood vessels that was entering the tooth through the apex has been severed, has been broken off. Okay, so the chances are this tooth will have pulpal necrosis down the line, and then we must perform RCT in due course. Maybe in 2 to 3 weeks we must start doing RCT. So this is lateral subluxation. All right, so this is some clinical pictures from a central incisor 1-1 which has been labally luxated, lateral luxation. The radiograph shows it's luxated. The tooth will show fortightening. Okay, the tooth will appear shortened on the radiograph because it is luxated, and then you have to reposition the tooth back, and then you have to put your stabilize with a flexible splinting, and then of course you will see that suturing has been done with black silk on the labial gingival tissues and the distal gingival tissues. So this is one case of lateral luxation. Okay, and then in the last series of these luxations we have intrusive luxation. The intrusive luxation, how the extrusive luxation was when the tooth has come out of the socket. Intrusive luxation is when the tooth is driven into the socket. Okay, so when it's driven into the socket, it will get wedged in the alveolar process, and then you will have tooth which is not mobile and which will have a metallic sound on percussion. So it's basically wedged inside. And when you take a radiograph, you will see that the apical periodontal ligament space has been obliterated. The space is gone, and the cemento-enamel junction of the tooth is apical to the marginal bone, or it can be also apical to the adjacent tooth. So this will help you come to the diagnosis of intrusive luxation. So if this happens, then you have to look at the apex, because the treatment differs. So if the tooth is having open apex, if the tooth is an immature tooth, you allow the tooth to spontaneously re-erupt on its own for 2 to 4 weeks. Okay, and if the tooth does not show spontaneous eruption, then you have to do orthodontic repositioning. That means you have to pull the tooth out using orthodontic chain brackets. Okay, and if the intrusion is more than 7 millimeters into the bone, okay, so this will definitely tell you. When I say 7 millimeters, I'm talking from the occlusion of the tooth. So if it is more than 7 millimeters, then you have to surgically extract the tooth. Okay, don't extract it, but yes, you have to disengage the tooth using your forceps, then pull it out in occlusion, and then you have to stabilize it with flexible splint, or again you have to do surgical exposure of the tooth and put a gold chain to the tooth, and then you have to pull it out. So this is for open apex. The situation is much better for the open apex because the apex of the tooth is wide open, the blood circulation is still there, and the tooth will live. You will have the closure of the apex in due course. But if the apex is closed, then we have a problem. So if the intrusion is less than 3 millimeters, the chances is that the tooth will erupt on its own into the normal occlusion in 2 to 4 weeks. And if it does not happen, then we have to go for orthodontic repositioning or a surgical repositioning. Okay, so this you can wait and watch. But if again it is more than 7 millimeters, the studies have shown that you have to do surgical repositioning and stabilization. Orthodontic repositioning will not work. So basically you have to take your forceps, hold the tooth, disengage the tooth, and then pull it out into the occlusion and then reposition it. And of course, like I said, the apical foramen is crushed. The tooth will lose its blood supply, and you have to do root canal treatment from the day you put your splint, okay, with 2 to 3 weeks after you put your splint, and then you have to give a calcium hydroxide dressing to ensure that there is no inflammatory tissue, pulpal tissue in the pulp canal, or otherwise you will have the problem of internal resorption. And if these necrotic pulpal tissues travel to the periodontal ligament through accessory canals, then you will have external root resorption. So you have to go for a calcium hydroxide dressing, which is very, very important in this particular case. So we are with intrusive. Now we come to avulsion. So avulsion is basically the tooth is knocked out of its socket. It's come out completely from its socket. It's also called as exarticulation of the tooth from the socket. All right. So most of the time when it happens, the patient will realize the tooth is missing, and then they will look around to find where the tooth is, and 99% of the time the child will find the tooth and bring it to you, maybe in a tissue paper or in a paper or in a plastic bag or things like that. But yes, the tooth will be accounted for. Okay, and of course when the tooth is not there, you will not see anything on the radiograph. So but if the tooth is not there, you have to take multiple radiographs to ensure the tooth is not intruded into the socket. It's not lost. For example, maxillary teeth is not lost in the nasal cavity, or it's not lost in the maxillary sinus. Okay, you have to look for all that. So you have to take a very good radiographic image if the tooth is not there. If the tooth is there, then it's a very clear-cut case, the tooth is out. So treatment will depend on, again, the status of the apex, if it is open apex or a closed apex. So the International Association of Dental Traumatology, they have come out with a decision tree for such kind of injuries. Now I have shared with you on the Google Classroom the document, so you can also go ahead and read the supporting literature to this particular decision tree. But basically what the decision tree tells you is that open apex is considered open when the apex is having a diameter of equal to or more than 1 millimeter. Okay, so basically what you need to understand here is the extraoral dry time. So extraoral dry time means the tooth has been knocked out and it is out of the oral cavity in the dry condition. Okay, and how long this is out in the dry condition will tell you what kind of treatment you have to do. Okay, so if the tooth is immediately put back into the socket after the extraction, after the avulsion, then you see on your left side the arrow which shows, and what you have to do, you have to re-implant and reposition tooth. You have to obtain a periapical radiograph and verify the position, and then place a flexible splint for 2 weeks and 4 weeks if the extraoral dry time is more than 60 minutes, and put in antibiotics and tetanus vaccination. And then of course the treatment that has to be done, you can read it on your own. But my point of telling you is that the extraoral dry time will decide what kind of treatment has to be done. So if you see on your far right where you have more than 60 minutes extraoral dry time or storage. Okay, so what happens here is that when the tooth is avulsed out of the socket, there are certain periodontal ligaments which have been severed from the socket, right? So periodontal ligament is the one that is holding the tooth on one side and the socket on the other side. So it gets severed. So there will be some periodontal ligaments if we try to keep alive, okay, there will be some mesenchymal cells in the periodontal ligaments. These mesenchymal cells have an opportunity to transform themselves into fibroblasts and then excrete the help in the formation of periodontal ligaments. So if we are able to preserve this mesenchymal cells and the residual periodontal ligaments, we can have the reattachment of the ligament when the tooth is put back into the socket. But the longer is tooth out of the socket, the chances is that these periodontal ligaments, these cells, mesenchymal cells will dry out and die. And once they die and you put it back into the oral cavity, the chances of ankylosis is very high. Okay, so this is one of the drawbacks for an avulsed tooth. You may have a proper periodontal ligament space, which is a best outcome, or you can have an ankylosis, that is a replacement ankylosis. Okay, which is also not bad, which will help protect the, which will help retain the tooth in the socket, but again it's not a very good outcome. So if you see on the far right, you have extraoral time of more than 60 minutes. So what you need to do is you need to debride the tooth root structure with pumice, prophylaxis, and gently do scaling and root planing to remove any residual periodontal ligament space. Then you have to condition the tooth with 3% citric acid for 3 minutes, and then you have to rinse well to remove all remaining periodontal ligaments. Then you have to dip the tooth in 1.23% sodium fluoride, that is your APF gel, for 5 to 20 minutes. So this will basically form fluorapatite on the root structure, and this will prevent the formation of external root resorption. Okay, so the chances of ankylosis is less. And then of course later you follow the same protocol. So keep in mind this, that has to be done depending on extraoral time. Again, I would like to bring your attention to something called as Hank's balanced salt solution. So when the tooth is out of the socket, okay, people try a lot of storage media to preserve the vitality of the remaining mesenchymal cells and the remaining periodontal ligaments. So among all the storage media, HBSS, that is Hank's balanced salt solution, was found to work the best. Okay, so this has become a gold standard. So when you talk about storage media for avulsed tooth, the best one is HBSS. Next best is your cold chilled milk. Okay, so you can put the tooth in the milk and it will preserve vitality of the remaining periodontal ligaments, mesenchymal cells, and then will give us an opportunity to reimplant the tooth back and then have regeneration of the periodontal ligament. Okay, so this tells you about this slide tells you about management of avulsed tooth with an open apex. This slide talks about management of avulsed permanent tooth with a closed apex. That means apex which is smaller than 1 millimeter. All right, so same protocol is there. Depending on the extraoral dry time, you need to take a decision on what steps you have to follow. So this is basically the steps you need to do. In the exam, you can be asked a modified essay questions on one of these scenarios, and we can tell you a patient has reported, a 10-year-old patient has reported with an avulsed tooth, and he has brought the tooth in a plastic bag, and he's requesting to save the tooth, and you have taken a decision to put the tooth back into the socket. And then the question will be, how are you going to do the clinical management? So you need to list out the steps, you need to know the steps, so that things like the patient's age you have to consider. So if it is a central incisor, the root completion is done by the age of 10 years. Okay, so if the patient is coming at the age of 8, that means it's an open apex. And then how much time is the tooth out, the extraoral dry time, it will be 20 minutes, 60 minutes, 40 minutes. You have to take a decision accordingly. Or if the tooth is brought to you in milk, okay, then you have to take a decision. So this is the decision plan, the decision tree that you have to consider when you are faced with reimplanting an avulsed tooth. Okay, so once that was all to do with the management of the injuries. This particular slide tells you the follow-up that you have to keep. Okay, the pulpal follow-up that you have to keep. For the different kind of injuries, you have different kind of follow-ups. So if you look at the table here, you will just realize that the minimum follow-up is at 2 weeks, and the maximum follow-up is yearly for 5 years. Okay, so let's say, for example, you have subluxation. Okay, so the subluxation, once you finish your treatment, you have to call back the patient after 2 weeks. When the patient comes back after 2 weeks, again you have to do clinical and radiographic examination to ensure the pulp is still healthy. And if the pulp is not healthy, you have to go for root canal treatment. If the pulp is still healthy, then you call the patient back again after 4 weeks from the day that ends on the 2nd week. Then when he comes back after 4 weeks, that is after about a month, then everything is okay. You call back at the patient after 6 to 8 weeks. After he's come back at maybe 6th week, he comes back, everything is okay, then you call him after 6 months. Then if he comes back after 6 months, everything is okay, you call after 1 year. So this follow basically tells you if any complication, pulpal necrosis will occur, it will occur within this follow-up period. Okay, and if it does not occur for subluxation at the end of 1 year, then it's very less likely it will ever occur after 1 year. But if you have root fracture, okay, in root fracture you have to do yearly follow-up for the next 5 years. Then only you will be sure that the tooth has healed completely and there's no need to look back at it. So similarly, when you have extrusive luxation, lateral luxation and intrusive luxation, you again have to do a 5-yearly follow-up. So every year he has to come for 5 years to ensure the tooth is safe. So most of the time pulp necrosis will happen within the first year, and then you have to start off with your root canal treatment. So many times it has happened in my clinical practice, the patient has come back with external root resorption after 6 months. Okay, and then we have to start the root canal immediately to prevent the spread of external root resorption. So this follow-up schedule is again given by the International Association of Dental Traumatology. So they have done a lot of research, and this is the summary of their clinical advice, clinical guidelines. Okay, so this brings us to the part of the splinting. So we have seen that whenever there is an injury to the supporting structure or the periodontal ligaments, periodontal structures, we have to splint the tooth. For us, when we splint, we have to put flexible splint. So when we say flexible splint, that means there must be some tooth movement after putting the splint. So it should not be a rigid splint. So the only the issue here is that if you put a rigid splint, that means the tooth cannot move at all. The chances of ankylosis is very, very high. So that is why we have to use flexible splint, and then you have to use those orthodontic wires which are flexible, and it allows certain amount of flexibility of the tooth so that there is the chances of ankylosis is not there. So the table that is shown in this slide tells you the period of splinting. So for subluxation, you have to go for 2 weeks. For extrusive luxative injuries, you have to go for splinting of 2 weeks. When we say 2 weeks, is that if the periodontal ligament has to regenerate, it will take 14 days to regenerate. The research shows the periodontal ligaments will regenerate in 14 days, so 2 weeks. So that is the time when you have to remove the splint and see if the tooth has regained its firmness or is it still mobile. So for lateral luxation, splinting period is 4 weeks, intrusive luxation 4 weeks, root fracture is 4 weeks, but if the root fracture is in the cervical 1/3, you have to go for 4 months. Okay, then if you have the root fracture, this is a repetition of the whole thing. 4 weeks if it is apical or middle third, and 4 months if it is in the cervical third, and if the tooth is avulsed, the splinting period is of 2 weeks. Okay, so what happens is after 2 weeks, when say for avulsion, you put a splint for 2 weeks, and after 2 weeks when you remove the splint, you find there is still some mobility, you may go for another 2 weeks of splinting. So it's okay. Okay, but you cannot go for more than 4 weeks of splinting. Then you have to take a decision if the mobility still exists, what to do with it. So if the extraoral dry time for avulsion is more than 60 minutes, then you have to go for 4 weeks of splinting. So because it is the dry time is more than 60, we are not looking at the regeneration of the periodontal ligaments. We are looking on maybe looking at ankylosis, which may be the most favorable outcome in this particular scenario. So we have to wait for 4 weeks for the ankylosis to happen. So this tells you the period of splinting. Okay, now we have different types of flexible splints. Okay, now what you see on your screen is the type of flexible splint. So the first one is your composite wire splint. So you take your orthodontic wire, 21 gauge wire, 22 gauge wire, and you use your composite resin and you splint the tooth. So you have to use the anchor of one tooth on the mesial side and one tooth on the distal side. Okay, so the tooth which is splinted has to come in the middle. Okay, so it takes the support of the two adjacent tooths. So this is a splint which is very common because the orthodontic wires composite resin are freely available in any clinic. Okay, so next one is you see on your right is the fiber splint. Okay, so these fiber splints are made up of glass fibers, and you can use your flowable composite to stabilize the tooth using the fiber splint, right? So again, the only problem with fiber splint is they are very expensive. Okay, so fiber splint is one technique you can use, and then what you have is your orthodontic wire and bracket splint. Of course, you need to have orthodontic brackets in your clinic to perform this, but again, this can be done. And the last one that you see on your screen on the right side bottom is your titanium trauma splint. So this splint was basically developed because it is very flexible, and then the holes that you see, okay, it is very good for anchorage also for the composite resin, and somehow it gives a better result. But again, all these types of splints are still under research. These have been shown to work very well. The research area is still open on any better splint which does not cause trauma to the tooth, does not cause trauma to the soft tissues. Okay, it is comfortable for the patient. So the thing is still open to research. All right, this slide is particularly important when you get a phone call from a school, and the school nurse says, doc, I have a child who has just knocked out his tooth, what should I do? All right, so this is what you should tell the nurse, and the nurse should also have the picture of this posted in her room. So what you need to tell, or what you need to make people aware, is that if you have a broken tooth, find that piece of broken tooth, because we can put it back using tooth fragment reattachment procedure. So find that tooth if the tooth is broken, or if the tooth is knocked out, you find the tooth, you hold it by the crown, wash it under the running water, and make sure that you plug the sink. Otherwise, if the tooth slips from your hand, it goes into the sink and then goes down the drain, and then we have another problem to look into. So make sure the sink is plugged, and you hold the tooth by the crown and you wash it under running water so that any dirt that is there on the tooth is get washed away. Then you need to put the tooth back into its socket, okay, and then probably bite on a handkerchief, close the mouth, bite on a handkerchief, and bring the child to the dentist. Sometimes the child is too young and he cannot hold the tooth into the socket. You cannot put the tooth into the socket. Then you put the tooth in a cup of milk or saline, but milk is always better. Saline is the prognosis is very poor with saline, but if you have nothing, at least keep the tooth moist to use the saline. But milk you can find anywhere. You put the tooth, avulsed tooth in the milk, and get the child and the tooth to the dentist so that we can reimplant it back to you. Remember, using the decision tree on avulsion. On the right side, you see something with the forceps and a tooth in the forceps, and the container which says save tooth, saves knockout teeth. So this is one of those commercially available kit which contains HBSS. So if the tooth is knocked out, you wash the tooth in the running water and you put the tooth into this container, and you get the container and the child to the dentist. So the tooth is in HBSS solution, and then this solution has a small basket. This container has a small basket inside with which you can rinse and you can take out the tooth without touching the root structure of the tooth. So basically, when you say not to touch the root, is basically not to damage any remaining periodontal ligament. So this is the first aid, the advice that has to be given to each and everyone to be aware of. All right, so once you have the traumatic injuries, a certain home care that the child must take. The child must be put on soft diet for 3 to 4 days. So this is for the pain to come down and the splinting to settle down. So the child has to put on a soft diet. Then we have to maintain fluid intake, make sure the child is drinking a lot of water, juices to maintain hydration. Then of course, oral hygiene. Brushing may be difficult, so you have to put the child on a mouthwash twice daily, chlorhexidine mouthwash, 0.12% twice daily for only 1 week, just to maintain a good oral hygiene. We don't want any bacterial infection because there is a trauma. The chances of infections are very high. Then if you have an intrusive injury, avoid pacifiers and bottle feeding. Okay, because of the sucking may happen, the child may glub the tooth, swallow the tooth. And lastly, ask the patient to inform if anything out of the ordinary happens. Come to the clinic immediately. Okay, so all said and done, this should have been the first slide of the presentation. But normally, by the time anyone comes to you, they already have a trauma. So it is our duty to educate the child, parents, on prevention of traumatic dental injuries. And these are some things which I have listed out for you. If followed, the injury to the child will be avoided. Most of the injury happens around the swimming pool when the child slips in the water and hits his face on the margin of the pool and then fractures the tooth, or when the child is playing, having a sports activity and somebody's elbow hits the face and the tooth gets fractured, or things like the child is sitting in the car and you put a sudden brake and the child flies and hits the dashboard and then the tooth gets fractured. So all of these things can happen, and if the preventive measures are taken, the dental injuries can be avoided. The last point that you see is early treatment of large overjet. Studies have shown children who have got Angus class 2 division 1 malocclusion, because of the protruded central incisors, these children are more prone to fracture. Obviously, because if anything happens to the face trauma, the teeth will be the first to come in contact. So these children are prone to traumatic injuries of the central incisors, and you must identify and have early treatment done for these patients. So this brings us to the end of this session on traumatic injuries, their management in permanent dentition. I want you to spend 5 minutes to recapitulate the main headings of the presentation. This presentation is quite long, so just spend some 5 minutes, try to recall the main headings. All right, and then I strongly recommend that you go and read the supporting literature that I have put on the Google Classroom to support your learning, and you must be very familiar with the International Association of Dental Traumatology guidelines. They have a website, and you can go to their website, and they have a lot of interactive exercises there you can do, and you can strengthen your learning there. All right, so that's it from me. This is Dr. Fawaz from Department of Pediatric Dentistry. I hope you had a good time, and see you again in the next lecture. Bye bye.